The final report from the CAS review was published on the 9th of April 2024. On the website it stated, "To provide an evidence base upon which to make its recommendations, the review commissioned the University of York to conduct a series of independent systematic reviews of existing evidence and new qualitative and quantitative research to build on the evidence base." In the foreword of the report, Hilary Cass writes, "This is an area of remarkably weak evidence, and yet results of studies are exaggerated or misrepresented by people on all sides of the debate to support their viewpoint. The reality is that we have no good evidence on the long-term outcomes of interventions to manage gender-related distress. Based on a single Dutch study which suggested that puberty blockers may improve psychological well-being for a narrowly defined group of children with gender incongruence, the practice spread at pace to other countries. Some practitioners abandoned normal clinical approaches to holistic assessment, which has meant that this group of young people have been exceptionalized compared to other young people with similarly complex presentations. They deserve much better." In a message to children and young people impacted by the report, Hilary Cass writes, "What I want to be sure about is that you are getting the best combination of treatments, and this means putting in place a research program to look at all possible options and to work out which ones give the best results. There are some important reasons for this decision. Firstly, you must have the same standards of care as everyone else in the NHS, and that means basing treatments on good evidence. I have been disappointed by the lack of evidence on the long-term impact of taking hormones from an early age. Research has let us all down, most importantly you. However, we cannot expect you to make life-changing decisions in a vacuum without being able to weigh their risks and benefits now and in the long term, and we have to build the evidence base with good studies going forward. That is why I am asking you to join any research studies that look at the longer-term outcomes of these interventions so you can help all those coming behind you. We have to show that the treatments are safe and produce the positive outcomes you want from them. Secondly, medication is binary, but the fastest growing group identifying under the trans umbrella is non-binary, and we know even less about the outcomes for this group. Young people who identify as non-binary are being medicalized. Now, queer theorists require the non-binary category to dissolve the binary opposition between male and female, because binary oppositions are regarded as inherently hierarchical and therefore oppressive. In the summary of the report, it states, "From the start, the review stepped into an arena where there were strong and widely divergent opinions and supported by adequate evidence. The surrounding noise and increasingly toxic ideological and polarized public debate has made the work of the review significantly harder and does nothing to serve the children and young people who may already be subject to significant minority stress." The context of the report explains the history of gender-affirming care. In 2007, Norman Spack established a clinic in Boston, United States, modelled on the Dutch protocol, and began prescribing puberty blockers from early puberty, Tanner stage 2. Practice in the United States began to diverge from the models of care in Canada and the Netherlands, following instead a gender-affirmative model advocated by Diane Ehrensaft. She described the three approaches as follows. The first model, represented in the work of Dr. Susan Bradley and Ken Zucker, assumes that young children have malleable gender brains, so to speak, and that treatment goals can include helping a young child accept the gender that matches the sex assigned to them at birth. This model, which was used at GIDS until 2011, was condemned by Ruth Hunt, who described Zucker's method as conversion therapy. The second model, represented in the work of practitioners in the Netherlands, allows that a child may have knowledge of their gender identity at a young age, but should wait until the advent of adolescence before engaging in any full transition from one gender to another. This model of care was trialled in an early intervention study at GIDS between 2011 and 2014. The results of the study were not published until 2021. In a 2019 paper, sociologist Michael Biggs wrote that although the head of GIDS described the results of the intervention study as being positive, in fact, the initial results showed predominantly negative outcomes. The only tabulated data available for 30 of the subjects after a year on triptorelin showed that children reported greater self-harm, girls experienced more behavioural and emotional problems, and expressed greater dissatisfaction with their body, so drugs exacerbated gender dysphoria. Hilary Cass's quotation of Diane Aronsaft continued. The third model, represented in the work of an international consortium of gender-affirmative theoreticians and practitioners, allows that a child of any age may be cognizant of their authentic identity and will benefit from a social transition at any stage of development. As Aronsaft explains.
So let me give you an example. I have a colleague who's transgender, and there is a video of him as a toddler. So he was assigned female at birth. There's a video of him as a toddler tearing barrettes out of then her hair and throwing them on the ground and sobbing. That's a gender message. And when it happens not just once or twice or 3 times, that's a gender message. Sometimes kids between the age of 1 and 2 with beginning language will say, I boy, when you say girl. Those 2 words, I boy. That's not a pre-verbal, but an early verbal message. And sometimes there's a tendency to say, well, honey, no, you're a girl because little girls have vaginas and you have a vagina, so you're a girl. And then when they get a little older, you'll hear them say, did you not listen to me? I said, I am a boy with a vagina. Okay, but they can't say that between 1 and 2. But they can show you about what they want to play with, and if they feel uncomfortable about how you are responding to them and their gender, if you're misgendering them. So you look for those kinds of actions, like tearing a skirt off. There was one, I think this was in the Barbara Walters special, where this child wore the little onesies with snap-ups in between the legs, and at age 1 would unsnap them to make a dress and have the dress flow. This was a child who was assigned male. That's a communication, a pre-verbal communication about gender. And the message back should not be to negate any of those expressions, but to go with them.
The third model, the affirmative model, has subsequently become dominant in many countries. As a result, some gender services have moved away from a more exploratory approach. Regarding social transition, the report states, given the weakness of the research in this area, there remains many unknowns about the impact of social transition. In particular, it is unclear whether it alters the trajectory of gender development and what short and longer-term impact this may have on mental health. Early research cited in Chapter 2 found low rates of persistence of childhood gender incongruence into adulthood, around 15%, for example, Zucker, 1985. Papers from this period were criticized because the children were not formally diagnosed using ICD or DSM. At that time, it was rare for children to have socially transitioned before being seen in clinic. Later studies, which showed higher rates of persistence at 37%, for example, Stainsmore et al., 2013, did use formal diagnostic criteria, but by that time a great proportion of the referrals had socially transitioned prior to being seen. It is not possible to attribute causality in either direction from the findings in these studies. This means it is not known whether the children who persisted were those with the most intense incongruence and hence more likely to socially transition, or whether social transition solidified the gender incongruence. The Welsh Government LGBTQ+ action plan is fully supportive of social transition. Although the action plan does not mention puberty blockers, it does reference an article by trans-identified male Florence Ashley, which states that unbounded social transition and ready access to puberty blockers ought to be treated as the default option, and support should be offered to parents who may have difficulty accepting their youth. Regarding puberty blockers, the report states, there are many reports that puberty blockers are beneficial in reducing mental distress and improving the well-being of children and young people with gender dysphoria. But as demonstrated by the systematic review, the quality of these studies is poor. The review has heard that the widespread claims that puberty blockers reduce the risk of death by suicide in this population may place pressure on families to obtain private treatment. The review has also heard from GPs who have been put under pressure to continue prescribing such treatments on the basis that failing to do so will put young people at risk of suicide. The University of York systematic review found no evidence that puberty blockers improve body image or dysphoria, and very limited evidence for positive mental health outcomes, which, without a control group, could be due to placebo effect or concomitant psychological support. Cass has debunked the gender-affirmative model of care. The Welsh Government LGBTQ+ Action Plan was created by members of the Welsh Government's independent LGBTQ+ expert panel. Many members of the panel are unhappy. Kate Hutchinson tweeted a link to an article by advisor at Transmedia Watch, Jenny Commode, that claimed the Cass review was methodologically flawed. Here's my article on why the Cass review is bad science but suits the politics of a desperate Conservative government at the expense of vulnerable children. Commode wrote, her approach included setting a very high bar for evidence to be considered in the review, ruling out 100 of the existing 103 studies into the use of puberty blockers and hormones to treat children. The reason given for excluding all these studies was that they did not incorporate a double-blind approach. In other words, they did not involve giving puberty blockers to some patients and placebos to others. This is untrue, as explained in a BBC radio podcast, Behind the Stats.
This work has been extremely influential. The National Health Service in England has stopped prescribing puberty blockers to these groups unless they're part of a research project. But before the Cass review was even published, an idea was spreading on Twitter that it was all based on biased information.
The Cass review only managed to get to its conclusion by ignoring 98% of the available evidence.
Do not listen to the Cass review. They literally threw out 98% of evidence.
Cass must be made to answer tomorrow why someone who understands paediatric research methodology chose to reject 98% of it when concerning trans young people.
This idea that 98% of the evidence was ignored or dismissed has been repeated again and again. So is it true?
That's completely incorrect.
This is Dr. Hilary Cass, a former president of the Royal College of Paediatrics and Child Health, and she was asked by the NHS to chair the independent review. As part of that work, Dr. Cass commissioned academics at the University of York to carry out a series of systematic reviews, which bring together, analyse and weigh up existing research.
So what the systematic reviews did was to evaluate all of the evidence, and there were only 2 studies that were deemed to be high quality.
Across 2 reviews, one into the use of puberty blockers and one the use of hormone treatments, there were 103 scientific papers analysed, so 2% were considered high quality, 98% not. But all the other studies weren't just thrown out.
There were quite a number of studies that were considered to be moderate quality, and those were all included in the analysis. So nearly 60% of the studies were actually included in what's called the synthesis.
That's the conclusion bit at the end. Now, this is where another criticism comes in. Many people claimed on social media that the reason such a small proportion of studies were considered high-quality research was because only one type of study was acceptable. The so-called gold standard of research, double-blind randomised control trials. These are where patients are randomly assigned to either a treatment or a placebo group, getting either a medicine or nothing, and neither the patient nor the doctor knows which one they're receiving. That is hard to imagine in this context, as Hilary Cass agrees.
Obviously, in this area of medicine, young people can't be blinded to whether they are on puberty blockers or masculinizing or feminizing hormones because it rapidly becomes obvious to them. But that of itself is not an issue because there are many other areas where that would apply. If you were doing a trial, say, of acupuncture, people would know exactly what treatment that they were getting.
So were these near impossible criteria used in the systematic reviews? Well, no. Professor Catherine Hewitt was in charge of the team at York University which conducted the research. She says they found no randomised control trials at all, so they decided quality in a different way.
We didn't identify any randomised controlled trials, but we had non-randomised studies. So we used an appropriate tool for those types of studies. So it's called the Newcastle-Ottawa scale, and that's appropriate for non-randomised studies.
Lisa Power retweeted similar allegations. And she reposted a tweet stating, "Fuck the Cass review, trans youth know what they want and they need. It's not being pathologised or patronised." Lisa Caudry-Bruce, a specialist nurse working for Cardiff and the Vale University Health Board, reposted the same tweet. Kat Burton tweeted that Hilary Cass totally discounted evidence from trans people on the basis of knowledge or lived experience. Useless. Sophie Quinney signed a letter written by the Feminist Gender Equality Network. The letter stated, "As a network of expert feminist academics and stakeholder groups who work on gender diversity, we are dismayed at the recommendations of the Cass Review for NHS provision of gender identity for services for children and young people. The Feminist and Gender Equality Network urges the NHS not to act on these recommendations. We suggest that the Cass Review contains unsound methodology, unacceptable bias and unsupported conclusions. As academics and experts in the field, we regard the Cass Review as potentially harmful to trans children. As academics with a wealth of research experience between us, we can confidently say that the Cass Review is an inadequate piece of research. Its methodology is unsatisfactory and unreliable. It disregards the wealth of expertise at national and international levels on best practice guidelines to support young trans people. It does not include a proper systematic literature review since it disregards most research evidence because it fails to reach the impossibly high bar of a double-blind trial. In fact, trans healthcare is inappropriate for a double-blind trial since you cannot give hormones to one group of people and not to another. This practice would be unethical. Indeed, much medical practice is not based on this kind of evidence. The claim that the systematic review ignored all research that didn't involve double-blind trials is untrue. In an article for The Times, Dr. Cass is reported as saying, "If you deliberately try to undermine a report that has looked at the evidence of children's healthcare, then that's unforgivable. You are putting children at risk by doing that." As of the 22nd of April, the Welsh Government have yet to respond.